So before starting with the stations regarding the skin melanoma, squamous cell carcinoma, basal cell carcinoma, gangrene, and actinomyces and abscess, let's revise some of the important anatomy as well as physiology of part of the skin. So the skin has got the layers called as epidermis and dermis. These are the basic two layers. So you can see this is epidermis. It has got 5 layers. So basal is the lowermost. So if you see this is skin, this upper part is epidermis and this part is dermis, then below is a subcutaneous tissue. You can see this, if you can see, these are the layers. Epidermis is this much. So here there are pores for the sweat gland, pores for the hair follicles, like this. So what happens, the epidermis has got this basal layer is the deepest, and then it goes basal, spinosum, granulosum, lucidum, corneum. So stratum corneum is the most superficial. The dermis had got papillary and reticular. So you see the dermis, it has got this is dermis complete from here to here. It has got papillary and reticular dermis. So you can see the hair follicle is very much deep inside the dermis and it touches the subcuticular plane also. And you can see this is the sebaceous gland and the gland, sweat gland. So this is the structure of the skin. Just we have to remember, because the tumors and the malignancies like basal cell and squamous cell carcinoma, it depends upon it. So when you speak about the skin tumors, the most common stations are squamous cell carcinoma, basal cell carcinoma, and the melanoma. So before going to that, you should understand differentials when there are benign lesions. This is basal cell papilloma, warts, freckles, lentigo, moles, nevi, junctional nevus. So these are some of the benign, like scrotal epidermal cyst. This can be milia, and this one is a basal cell papilloma, and this one is junctional nevus. So just keep in mind some of the benign tumors of the skin. This is again a compound nevus, and you can see intradermal nevus. So nevi, these are the nevi. Nevi are the benign tumors. Then you get some of the things of the hair follicles. These are the Spitz nevus, halo nevus, and these are the cephaloid spots or giant nevus. So you get, these are the different types of nevus. You can see this one is the blue nevus. Now some of the things, pre-malignant lesions. This is actinic keratosis. This is pre-malignant. Then keratoacanthoma, there is a keratin pearl. Here is this one is keratoacanthoma. So this has to be differentiated from the basal cell carcinoma. So the difference is, here you get what is keratoacanthoma. There is a keratin pearl in between. This is papilloma virus and the hair follicle. So it's basically etiologic keratoacanthoma, but caused by papilloma virus. So Bowen's disease, this can be one of the differential in carcinoma in situ, squamous cell carcinoma. So these are some of the Bowen's disease, squamous cell carcinoma in situ. So erythroplasia of curate, then Paget's disease. So now you have to think of malignant lesions. So the questions, the stations are coming for basal cell carcinoma. So the basic pathology you have to understand is very slow growing, locally invasive malignant tumor of pluripotent epithelial cells arriving from the basal epidermis. So this is the thing you have to understand, that it is from the basal epidermis, 90% nodular, no cystic. Exposure, sun exposed areas, ultraviolet radiation, that can be other high risk lesions are exposure to aromatic hydrocarbons, ionic radiation, and genetic skin. So this is the dysplastic nevus. Now what is the pathogenesis? So it rarely metastasis, it is locally invasive. So macroscopic, you can be divided into nodular, cystic, pigmented, nevoid. So there are different macroscopic appearances. So microscopy, there are different types, the single palaciding. So this the histopathology, it shows periphery of the tumor. You see there is palisading at the periphery of the tumor with mucinous stroma. So this is most of the time asked. Morphic basal cell carcinoma, then prognosis is low risk and high risk. How is the management? This question is asked. Mohs microsurgery. So it has been demonstrated. What is that? Mohs microsurgery is using frozen section or immunohistochemistry and use excision of, it can be used for, what is the surgeon is under local anesthesia, suturation, excision, and they go on doing it. Hematologist scan, this H&E staining, and you excise the part. So it can be managed by topical this. Now this is about the squamous cell carcinoma. It is arising from stratum germinatum. So it is superficial layer, second most common, sun exposed area, chronic inflammation, sinus tracts, scars, any other thing it can lead to. It can be squamous cell appears in the scars called marginal ulcers. Human papilloma virus can also lead to it. Chronic inflammation. So how is the treatment? Appears maybe smooth, macroscopic appearance may be papillomatous ulcerating lesion. So how you get this is, you can see this one is the squamous cell carcinoma. So here there is ulcerating lesion, and what you find is around positive for cytokeratin, Broders grading is there. Prognosis is depth depends upon the depth, and worst prognosis less than 2 millimeter. Surface size more than 2 centimeter. And histological grading, high grade, it depends upon the Broders grading. So site squamous cell carcinoma on the lips and ear has local recurrence. Burn scars and on osteomyelitis. This can lead to immune suppressed patients. Management is again the excision, therefore it must be addressed. And surgical excision only means provide 4 millimeter clearance margin should be achieved if squamous less than 2 centimeter across. So cutaneous. Now coming to the melanoma. This is very commonly asked. Station melanoma is ultraviolet radiation, most common cancer in the young patients. Now what happens? This is ultraviolet exposure is the reason. Rising incidence, genetics, superficial spreading form the most common, and biopsy has to be done. The risk factors for malignant melanoma are xeroderma pigmentosa, past medical history, nevus are large, dysplastic nevus, radial. Pre-existing nevus. So in 10 to 20% malignant melanoma arise from the pre-existing lesions. Most common likely nevus is to form a junctional nevus. So you change in the size. How to suspect? Macroscopic features in nevus suggestive of malignant nevus converting into melanoma. Change in size more than 6 millimeter in suspect. Then anything changing from more than shape, color, thickness, satellite lesions, tingling, itching, serosanguinous discharge, blood supply. So this is the causes. So different types, superficial spreading, most common, 70% of the patient has superficial spreading. Then darker pigmented, then so this is superficial spreading nevus, and this one is nodular. So nodular is the next common. 15% of the patients get nodular blue back papules 1 to 2 centimeter. Then Hutchison-Meckel prickle. So this is lentigo maligna. So this is lentigo maligna. What are the features of lentigo maligna? The variant slow growing macule, face, neck, and heart. Then acral lentigerous. So acral lentigerous. So this can be acral lentigerous. Acral lentigerous. So acral lentigerous. These are the different types. Then again, dermoepidermal junction. Management is excision, biopsy 2 to 5 millimeter. Then local treatment can be skin malignancies. Now what we are going to do is about basal cell carcinoma. So the stem you get is a 78-year-old female having some ulcer, skin ulcer over cheek. So what are the differential diagnoses, what can you suspect, and how is the macroscopic appearance, means general clinical appearance. So appearance, it can be a papule, benign, purely, and what can you see if it is suspecting basal cell carcinoma? There is central ulcer, then you can find granulation at base, you can find inverted edges, and telangiectasia. Telangiectasia. This is a very typical feature of basal cell carcinoma, telangiectasia, pink non-metastatic. So what can be the differential diagnosis? It can be basal cell carcinoma, squamous cell carcinoma, tuberculosis of the skin, or actinic keratosis. So you have to mention these things. So what is the natural history of basal cell carcinoma? How will be BCC? So what happens? It is a slow growing, indolent, and locally destructive. So it doesn't spread fast, and limited potential to spread. So it doesn't spread. Examiner gives histology report. What you look in the report? So basically, when the report is there, what are the important thing? Histology. So as you have seen, it is arising from the basal cell, so it is called as basal cell carcinoma. That you need the deep margin and size, depth, margin, and size. These are the two things you see. Basically, if margins are unclear, margins are still there, you have to do re-excision, frozen section, or Mohs microsurgery. So this is the important word, Mohs microsurgery. If lymph nodes are involved, if you suspect a lymph node, you have to do biopsy, excision biopsy. What is frozen section? Frozen section. So frozen section is a method where laboratory allows you to quick microscopic on table. Whenever surgery is going on, you have to diagnose on table. Rapid pathological diagnosis. So what are the steps? A surgeon is, while doing surgery, takes the tissues from the procedure of the tumor and send it to analysis to pathologist. Then pathologist, what do pathologists do? He freezes and do sections on it and make a slides, and that gives a section will be obtained, and report is reporting. So this reporting done when the surgery is going on, and it is informed to the surgeon. So how do malignant cells? Now lymph nodes, how this is the tumor and this is lymph node. How do they travel to the lymph node? Malignant cells travel to lymph node. So a cancer cell, they secrete the growth factors. The cells secrete the growth factors that causes growth of lymphatic capillaries taken up by the growth factors which are taken by the lymphatic capillaries. These growth factors cause lymph angiogenesis. So new vessels, angiogenesis. So new lymph and vessels are formed so that the tumor cells are sprayed. If suppose the patient has got excision is done and the graft is applied and graft gets failed. So what can be there? It can be wound infection, it can be hematoma below the graft, or the graft is rejected. These are the things. What are the organisms? Staph and strepto. What to do for? Then you have to take the swab and send it for send it for culture sensitivity. Then what is MRSA? This is very common for the skin infection. Methicillin resistant staphylococcus. Methicillin resistant staphylococcus. coccus aureus. This is very means patients. This is a common cell, is very common and it cannot be eradicated. So what you do, you isolate the patient. Isolation is important. Infection control team has to be informed. Then wound has to be debrided and antibiotics has to be given. So for nasal, there can be nasal carrier or skin carrier. Nasal and skin carriers. So carriers are to be decolonized by mupiricin nasal spray or chlorhexidine for the skin and the body shampoo. So ward nurse is involved for this, microbiologist is involved, and then you have to inform the infection control team. Patient develop axillary lymph nodes, lymph node biopsy large cells. If axillary lymph node is there and bilobed cells, so what can be the possible? These are different diagnosis of the skin and tumors. So eosinophilic, this is eosinophilic. So eosinophilic bilobed, it is called as owl's eye. Owl's eye is Reed-Sternberg cells. It is Hodgkin's lymphoma. So what is the diagnosis? Hodgkin. Then different. What is carcinoma? So carcinoma is a epithelial cells malignancy. Features of malignant cells. How to differentiate between malignant and benign? What are the features of malignant? So they have got mitotic figures, mitosis abnormal, increased number, abnormal size, hyperchromatism, color is dark, nucleus is dark, pleomorphism, shape is also there, pleomorphism, shape of the nucleus is also there, nucleus cytoplasm ratio, nucleus is increased, so nucleus cytoplasm ratio is deranged. So these are the things for the basal cell carcinoma. So how will they stem for squamous cell carcinoma? So it can be squamous cell carcinoma, and the stem is like this. What you get is a man, 64 year, referred by GP, 25 millimeter right arm skin ulcer, punch biopsy is performed. So skin lesion is reported showing squamous cell carcinoma. What is carcinoma? So again the question is, what is carcinoma? Epithelial cell malignancy. So surgical excision tumor is having histopathology report might indicate aggressive potential tumor. So what do you mean by aggressive? What are aggressive tumors? So it can be deep penetration, spread to lymph, spread to blood vessels, high mitotic, so nuclear activity, and differentiation, poor differentiation. These are the aggressive tumors. What two treatments are appropriate for incomplete excision tumor at the site? If there is incomplete excision, so you have to achieve re-excision on radiotherapy. You have to go for radiotherapy. So re-excise to radiotherapy. Incomplete may have frozen section histology. And then again the same thing, how it is frozen section, it has to be fixed in paraffin and all that. 10 days following excision, wound grafting is done. Operation site noted to have 50% blockage and leakage fluid. So laboratory report MRCS positive. So this is methylene resistance, so graft failure, and there can be decolonization. So you need to colonize this by antibiotics, screening patient for swabs, giving. The wound develops granulation tissue. What is granulation? Now there can be, what is granulation? Granulation. So granulation tissue is vascular, newly growing vascular loose connective tissue. It growth into spaces and defects and fibroblasts. Sclerosis in the form of scar permits revitalization. So this is about. So important stem is 33-year man. GP has referred forearm lesion, and report reads that epidermis and dermis in which proliferation of non-pigmented epithelioid melanocytes. So when melanocytes are there at the junction and invading the dermis up to the deep margin, feature of those of malignant melanoma. Already it is given. So malignant melanoma. Now what to do in this? What is difference between melanoma and squamous cell carcinoma? Now we have to differentiate between the two. Now this is melanoma is from the melanocytes, and squamous cell carcinoma are the epithelial cells. Then it is the melanocytes are the deeper layers, these are the superficial layers. Treatment. What treatment is indicated and consequence of pathology? Do further surgery to achieve complete. Describe 3 cell features of invading melanoma that indicate aggressive potential. Against aggressive. So aggressive melanoma means what is this? There can be tumor thickness. First is thick and depth. Second is depth and lymphatic or satellite lesions, neural invasions, ulcers. So this is they are supposed to be the aggressive. Satellite lesions means satellite. So these are the lesions which are away from the main tumor. Pathological features regarded good prognosis. What are having good prognosis? Superficial, limited depth, no lymph nodes. No lymph node, limited depth or superficial. So why sun exposure is factor? What does sun exposure do? Sun rays are ultraviolet. They cause DNA damage. So damage to DNA causes most of the time mutations. So these mutations lead to melanoma. Inherited conditions which can lead to are xeroderma pigmentosa and dysplastic nevus syndrome. If the person is having 1 mm thick and excision margin is 0.5 mm, is it okay? No, needs further exercise. So the excision has to be done more. Basically it is 0.5 to 1 centimeter if it is in situ. If the thickness is less than 1 millimeter, it has to be at least 1 centimeter and above. 1 to 4 millimeter, it has to be more than 2 centimeter. So 2 centimeter margin has to be there if it is more than 1 millimeter thickness. So what is the next page? Then you have to go for this. Now Breathless and Clark, these are the 2 things which has to be considered. Now skin suspicious of melanoma, they have got lesion, suspicion of melanoma, A, B, C, D, E, asymmetry, border irregularity, color change, diameter more than 6 millimeter, and evolution changes. So now what are the different which type of gene? So this is one of the question. BRAF gene. You have to rule out the genetic mutation. So if the patient has got axillary lymph node dissection, patient develops axillary vein thrombosis, or it can be the lymphedema. Two risk factors of thrombosis is satellite lesions, altered pulpo versus striate. What do you mean by phenotype? It can be known by immunohistochemistry. Where would you examine this lady? Primary sites, if the patient is having melanoma at the nail, so you examine the inguinal lymph nodes. What would you treat this lady? Excise the primary lesion with safety margin. And then what some of the questions regarding what is systemic inflammatory response syndrome. The patient has got infection. It can be so body temperature is more than less than 36 or more than 38. WBC count is less than 4,000 or more than 12,000. Heart rate is more than 90. Respiratory rate is more than 20. So if two of the factors are there, is SRS, it will lead to ARDS. So if inguinal lymph node was lymphoma, what are the different types? So it is Hodgkin's, non-Hodgkin's. So how do malignant tumors survive in the lymph nodes? They release the growth factors, vasculoendothelial growth factors, because they cause damage, induce lymphatic expansion, and they help to survive. So melanoma is pigmented. Why it is pigmented? Because of melanin. So this is the different types. Now you know different types of melanoma. These are superficial spreading, nodular, lentigo, and acral. So superficial spreading is very thick, nodular is nodular. So this has got good prognosis, most common. This has got bad prognosis. Acral lenticulus is also bad prognosis. Nodular is also bad prognosis. So what is the reason? So if the patient is having melanoma at the toenail, so you need to go for amputation because the margins cannot be achieved. What is epithelioid? The melanoma with cells representing epithelial, abundant eosinophilic sarcoma. What is satellite lesions? Gene mutation is BRAF. Post-operative infection is red and swollen. Culture gives diplococci. Examples of diplococci. So what you have to remember is Neisseria, H. influenza, Brucella, gram negative, H. influenza, and positive you have to remember of strepto and entero. So it spreads to the tissues, that is necrotizing fasciitis. So another pathology station where you can get with the skin lesions, that a person is having 25-year-old female having Crohn's disease and now ulcer over face. So it can be steroid or it can be immunocompromise. So patient is having so what to do for this? You take the swab and send it for culture and gram staining and microscopy and sensitivity. So if the pus is green, so what you suspect? Greenish colored actinomyces. So granules will be sulfur granules. Patient develops a sinuses after 6 weeks. After 6 weeks, patient develops sinuses. So wound doesn't heal. So it can be the local cause. There can be local, systemic, or medications. So local can be necrosis, osteomyelitis, poor blood supply, systemic immunodeficiency, malnutrition, or medications can be corticosteroids. So type of actinomyces bacteria, gram positive. Actinomycosis is not fungal, it is gram positive anaerobic bacteria. Sites of actinomycosis is neck, thorax, appendix. So jaw is the angle of cervicofacial actinomycosis. Patient develop mandible osteomyelitis. What are the causes? How can osteomyelitis? So direct trauma, local cells in the inflammation are chronic inflammation. Acute inflammation is acute cells will be neutrophils, and chronic you get mononuclear cells, macrophages, lymphocytes. Cause of enlarged lymph nodes, it because of inflammation. So if the tumor is there, that can be lymphoma. Functions of osteoclast reabsorption. Bone cells, different bone cells are so blast, sites, class, osteoclast, osteoblast.